Cholangiocarcinoma. Etiology, pathophysiology, and pathology. Chronic inflammation and bile duct stasis are associated with increased risk of developing cholangiocarcinoma, which is a malignant adenocarcinoma of the biliary tree with three main distributions. 1. Intrahepatic or peripheral tumors arising from bile ducts within the liver, usually mass lesions. 2. Extrahepatic tumors that are classified as proximal, near the liver, intermediate or distal, near the pancreas. 3. Klatskin tumor, which arises at the bifurcation of the common hepatic duct, leading to obstruction of both left and right hepatic ducts. Epidemiology. Cholangiocarcinomas comprise 5–10% of malignant hepatic tumors and are more common with increasing age, most patients greater than 60 years. The incidence is increasing in the Western world, cause unknown. Intrahepatic cholangiocarcinoma may be mistaken for a liver mass and therefore be underreported. Clinical presentation. The patient is often asymptomatic until a late stage, when symptoms include biliary obstruction, fever, weight loss, and vague abdominal pain. Some patients describe itching before jaundice becomes clinically apparent. Physical signs. Jaundice, with or without hepatomegaly. Weight loss. Biliary obstruction is usually proximal to the cystic duct, so the gallbladder is not usually palpable, negative Courvoisier's sign. Investigations. Liver biochemistry. Elevated bilirubin, alkaline phosphatase, and gamma-glutamyl-transferase. 2 more markers. CA19-9 rises, but does so in many causes of jaundice, benign and malignant, giving a low sensitivity and specificity, so it should not be used diagnostically, although it may be helpful in assessing response to therapy. Alpha-fetoprotein levels will not usually be raised, which can help to differentiate intrahepatic cholangiocarcinomas from hepatocellular carcinoma. Ultrasound and CT. Ultrasound detects dilated ducts, mass in pancreatic head, carcinoma, and level of obstruction. CT scanning adds little in these patients unless looking for distant metastases. Endoscopic retrograde cholangiopancreatography. This is usually the definitive test and is both diagnostic and potentially therapeutic. Fig 43. The sensitivity of cytology of brushing from the stricture is about 50–70%. Percutaneous transhepatic cholangiography. In the presence of a lower common bile duct, CBD, stricture, it may not be possible to cannulate the papilla endoscopically and the biliary tree has to be accessed percutaneously using percutaneous transhepatic cholangiography, PTC, Fig 44. PTC is also particularly useful in patients with proximal strictures or Klatskin tumors. Endoscopic ultrasound has been used to take tissue samples by fine needle aspiration. The use of many probes allows further assessment of biliary strictures by intraductal ultrasound in some centers. Differential diagnosis. Extrahepatic tumors must be differentiated from benign strictures, e.g. chronic pancreatitis, primary sclerosing cholangitis. Intrahepatic tumors must be differentiated from hepatic lesions, e.g. metastases, and hepatocellular carcinoma. Treatment. Short-term. Relief of biliary obstruction with a stent placed percutaneously, Fig 45, or endoscopically, Fig 46, is the mainstay of treatment for most patients. Different types of stent can be employed, selection depending on the predicted survival of the patient. Metal self-expanding stents remain patent for longer than cheaper plastic stents. NB. Metal stents cannot be removed and can make subsequent surgery difficult. It is therefore important to have made the correct diagnosis before inserting one. Long-term surgical resection. Appropriate in early disease if no evidence of spread. The procedure depends on the location of the tumor. Distal tumors may be removed by Whipple's procedure, with segmental resection for intrahepatic lesions. Klatskin tumors are almost never resectable. Roux-en-Y biliary anastomosis may relieve obstruction as a palliative procedure for low CBD cholangiocarcinomas. Liver transplantation. This is contraindicated in a patient with primary sclerosing cholangitis who develops a cholangiocarcinoma due to the high rate of tumor recurrence with immunosuppression. Complications. Secondary bacterial cholangitis, with or without a blocked stent. NB. The presence of cholangitis in the presence of a CBD stent usually indicates that the stent is blocked and is an indication for changing it, even if the liver biochemistry improves with treatment of the cholangitis. Prognosis. This is poor, with an overall survival rate of 40–53% at 1 year and 10–19% at 2 years. Disease associations. Well-recognized associations are primary sclerosing cholangitis, parasitic infections with liver flukes such as Clonarchis and Opistherchus, Southeast Asia, and recurrent bacterial cholangitis with hepatolithiasis. Exposure to thorium dioxide, thurotrast, alpha-1 antitrypsin deficiency, and Cholangiocarcinoma cysts have also been described in association with cholangiocarcinoma.